Bismillahirrahmanirrahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. Last time we started about neurosurgical concerns in relation to anesthesia and in relation to intensive care unit. Now we went through some physiological facts and quickly we went through the anatomical portions of the nervous system. This is central nervous system and peripheral nervous system. In central nervous system, the brain has got different portions like cerebrum, cerebellum, brainstem, spinal cord, and some sort of scary sonic structures like diencephalon and basal ganglia. In diencephalon, thalamus, epithalamus, hypothalamus, and subthalamus. Then in basal ganglia, you've got choroid nucleus, globus pallidus, putamen, claustrum, and amygdala. Then we quickly went through what are the basic structure, functional units of the nervous system. In central nervous system, it's called neuron. And in peripheral nervous system, that's called nerves, right? So then we talked about the structure of the neuron. Then in peripheral nervous system, you've got spinal nerves and then cranial nerves. There are 31 pairs of spinal nerves and 12 pairs of cranial nerves. And then we talked about a little bit about cerebral perfusion, cerebral circulation. Now there are two internal carotid arteries. 2/3 of the blood is supplied to the brain by internal carotid arteries, and there are two vertebral arteries. 1/3 blood is supplied by the vertebral arteries, and they make some sort of circle. This is called circle of villi. And if you look at it, it looks like spider. If you look at the circulation or their anastomosis network, that circle of Willis from below, it looks like a spider. Then we said, how much is the blood flow to the brain? It's about 40 to 50 mils per 100 grams per minute. And the brain weight is 1.4 gram. You can multiply it, around about 750 mils is going to the brain every minute. And then you can calculate the proportion of total cardiac output or proportion of total blood volume. Then how much is the cerebral metabolic rate of oxygen utilization, CMRO2? This is very important. So this is 3 mils per 100 gram of the brain substance per minute. And it's very important because we have to maintain this oxygen, this amount of oxygen to have the normal activity of the brain substance. Then we look at what is the critical blood flow. We went through that. The venous drainage by superficial veins and deep veins. Internal jugular veins, spinal venous channels, and vertebral venous channels. The nerve supply to the brain is sympathetic from cervical sympathetic ganglion, and parasympathetic is from the facial nerve via greater superficial petrosal nerve. Now, this is very important. How is the cerebral blood flow controlled? There are 5 systems which control the cerebral blood flow. One is metabolic regulation, chemical regulation, autoregulation, neurogenic regulation. There are some other factors like blood rheology which control the blood flow to the brain. Now, metabolic regulation is, cerebral blood flow is linearly related to the nerve cell activity. Greater the nerve cell activity, greater will be the blood flow to the brain. That's obvious. If the neurons are acting very fast, or neurons are active, so they need more oxygen. So the blood flow is increased and they supply the required amount of oxygen to the brain substance. It usually happens in epileptic seizures, in pain and anxiety. That's why we always say about the oxygen, when the patient has got epileptic fits, put the mask on the face, give oxygen to the patient, so that there should not be deficiency of oxygen on the vital organs like brain, then myocardium, then kidney, and to the gut also. Then painful stimuli post-operative period. Then I mentioned last time also, never ever try to demonstrate the pain after the operation on the brain substance, or if the patient has got intracranial insult, because little bit of pain stimuli can tremendously increase the blood flow to the brain can tremendously increase the ICP, intracranial pressure. So there should be other ways to assess whether the patient has to assess the Glasgow Coma Scale or to assess the neurological status of the patient. So then we talked a bit about anesthetic agents also. Out of all these regulations, autoregulation is very important. Cerebral blood flow is related to the perfusion pressure. What is the perfusion pressure? Mean arterial pressure normally is 60 to 130. If you maintain this mean arterial pressure in a normal person, so that keeps the blood flow to the brain constant. It doesn't matter how much is the perfusion pressure. So it will maintain the total blood flow to the brain at a constant level. So if you lower the mean arterial pressure less than 30, so then the autoregulation fails. When it goes above 130, then again autoregulation fails. Now, if the patient is hypertensive, I did mention last time that if the patient is hypertensive, this whole graph is shifted towards the right. It means the lower limit is also increased and the upper limit is also increased. So when we prepare these patients who have been hypertensive and they are going for intracerebral surgery or even otherwise, other surgery also, we have to control the blood pressure to bring this autoregulation within the normal range. Autoregulation of brain, autoregulation of heart, autoregulation of liver, autoregulation of kidney. They also works in the same way. So in a hypertensive patient, this whole curve is shifted towards the right. So if perchance during anesthesia we drop the blood pressure, then the organs suffer from hypoxia. And that hypoxic injury to the neurons or hypoxic injury to the myocardium, hypoxic injury to the liver, hypoxic injury to the kidney, that will be not immediately noted. It might after a few months, after a few years, you will see there is some problem now with this patient. Now when the patient has lost anesthesia, they might have damaged the cells of those organs because the patient was hypertensive and we did not control it, we did not manage it. Otherwise, during anesthesia, there's no problem to control the blood pressure. We can always drop the blood pressure. Almost all the drugs which we are using, they drop the blood pressure except with a one or two exception. So there is no problem. But the problem is autoregulation. We'll have to keep in mind our autoregulation when we anesthetize the patient. If it is not an emergency, then you should control it and maintain the blood pressure within normal range. Now, mean arterial pressure, as you know, is diastolic pressure plus 1/3 of pulse pressure. What is the pulse pressure? Means the systolic pressure minus diastolic pressure. And cerebral perfusion pressure is mean arterial pressure minus ICP, intracranial pressure. So, if you want to lower the intracranial pressure, never ever drop the blood pressure before. Cerebral perfusion pressure is a pressure at which the blood flow to the brain is maintained. So, if you want to normalize the cerebral perfusion pressure, never ever try to drop the blood pressure first before you start lowering the intracranial pressure. Always start from intracranial pressure, drop the intracranial pressure, then you drop the mean arterial pressure so that it should maintain the cerebral perfusion pressure. If you lower the blood pressure before you lower the ICP, the brain will suffer from ischemic insult. Then intracranial pressure, as we know, this brain has got 1400 grams of its weight. CSF is about 75 mils. Blood is about 75 mils. Normal ICP is about 10 to 15 millimeter mercury. Then we went through this all autoregulation last time. This also, chemical regulation is also important. Chemical regulation, when we think about it, we always think about the PCO2, carbon dioxide. Because of hypoxia, unless the PO2 is dropped below 60, it does not affect the cerebral blood flow to the brain. But CO2, with slightest increase in CO2, will tremendously increase the blood flow to the brain. So if you increase carbon dioxide by 1 millimeter of mercury, it will increase 4% of cerebral blood flow. When the PCO reaches up to 80, the cerebral blood flow is almost doubled. So these things has to be kept. When the patient is in ICU, keep these things in your mind because they can affect tremendously on the quality care of the patient. So it will have to go along with the patient. Look at the blood gases. Then neurogenically, if you increase the sympathetic system, if you stimulate the sympathetic system, it causes vasoconstriction, it will reduce the cerebral blood flow. If you stimulate the parasympathetic system, it will cause vasodilatation, that will increase the blood flow to the brain. That's linearly related to it, inversely linearly related to it. Then we went to blood rheology. If the blood is thick, less blood will be going to the brain. And if the temperature increase, it will increase the blood flow to the brain. And all the anesthetic agent, there are two types of anesthetic agent, intravenous anesthetic agent and inhalation anesthetic agent. Intravenous anesthetic agent, they decrease the cerebral blood flow. So that's why they try to decrease the ICP. But inhalation anesthetic agent, they cause vasodilatation. They increase the cerebral blood flow, they increase the ICP. These six should be kept in mind when you are anesthetizing these patients. Now, anesthetic agent, I divided into three groups. We went through this last time also. Group one is the intravenous anesthetic agent. They lower the CMRO2, they lower the cerebral blood flow, so they lower the intracranial pressure. They are beautiful drugs. We use propofol intravenously, we use barbiturates intravenously to lower the ICP. How do they lower the ICP? By decreasing the CMRO2, by decreasing the cerebral blood flow, by decreasing then they decrease the ICP. Group 2 is the volatile anesthetic agent. They lower the CMR2 because they suppress the neurons, but they cause a vasodilatation, they will increase the cerebral blood flow. So they will tend to increase the ICP, intracranial pressure. Now, exception to this is enflurane. Exception to first group is ketamine, right? So group 3 is in which is included ketamine and enflurane. Both will increase the cerebral blood flow, increase the CMR2, will increase the ICP. So one has to be careful when you are using these two types of drugs. In ketamine intravenously, enflurane as an inhalation anesthetic agent. Nobody uses it nowadays, but ketamine is commonly used, particularly in small hospitals. One should be very careful in using in neurosurgical anesthesia. Now, individually, we went through these, all inhalation anesthetic agent, intravenous anesthetic agents. Now, one important thing is luxury perfusion. We call cerebral steal and inverse steal. Now, it's the blood diseased part and other is normal brain. Here we have got normal brain and here we got normal brain and this is the diseased part of the brain. Now, if you give intravenous anesthetic agent, they will cause vasoconstriction in a normal brain. It means, what will happen then? Will it cause inverse steal or steal? What is the steal? Steal is, normal brain is stealing the blood from diseased part of the brain. Inverse steal is, the diseased part of the brain has got drawing blood from the normal brain. These are the two terminology which some people get confused. Intravenous anesthetic agents like propofol or barbiturates, they cause inverse steal because they cause vasoconstriction, so the blood is pushed to the diseased part of the brain. Now, inhalation anesthetic agent, they cause vasodilatation. So blood comes from diseased part is directed towards the normal brain. So that's called steal phenomena. So steal phenomena and inverse steal phenomena. Now, we went through these all last time. Barbiturates, sedative dose if you give, so it doesn't affect the CMRO2 or cerebral blood flow. Higher doses, if we use, CMRO2 will be decreased, cerebral blood flow will be decreased, ICP will be decreased. And it will cause inverse steal phenomena, as I mentioned earlier. Now, all these like individual drugs, so we should have a simple, basic formula. Now, narcotic analgesics, like people are using morphine, we are using fentanyl, alfentanil, sufentanil, remifentanil, all these drugs. One should know what is the effect on the brain. Now, morphine and pethidine, if you keep the PCO2 normal, don't let the narcotic agent suppress the respiratory system to increase the PCO2. If you keep the PCO2 normal, this morphine and pethidine will lower the CMRO2, will lower the cerebral blood flow. So it will lower the ICP. Now, fentanyl is 10 times more potent than the morphine, and it does not affect the CMRO2, but it keeps the cerebral blood flow normal. It depends how much you are using it. Then it's not properidol, it's a droperidol. Droperidol is butyrophenone drugs. They are neuroleptic drugs, which are commonly used. They are commonly used as a neuroleptic anesthesia some years back, but nowadays people don't use it. Now, droperidol will lower keep the CMR2 normal, but it decreases cerebral blood flow. Again, it is a good thing. Fentanyl plus droperidol. It's not properidol, it's a droperidol. It will lower the CMR2, lower the cerebral blood flow, lower the ICP. It used to be very good combination that you give fentanyl to start with, 100 microgram. You give fentanyl intravenously with the induction agent, then you run the drip of propofol as well as a fentanyl. And it stabilizes the brain cell, and it lowers the CMR2 and will lower the cerebral blood flow, will also lower the ICP. And the surgeon is happy and you are happy also. Right? Now, in neurosurgical anesthesia, there are basically three considerations, basically three important things. One is blood flow to the brain, other is cerebral metabolic rate of oxygen utilization, third is intracranial pressure. Now, cerebral blood flow depends on the vasodilatation and on the blood pressure, right? CMRO2, it will depend how is the activity of the neuron. If you suppress the neuronal activity, it will lower the CMRO2, it will increase the activity, it will increase the CMRO2. Again, it is a balance between the oxygen supply and the oxygen utilization. Oxygen supply and the oxygen requirement of the brain cell. If you suppress the brain cell, it will require less oxygen. So you don't have to worry about the oxygen supply then. Now, ICP depends on how much is whether you have increased the tissue fluids or not, or how good is the venous drainage. If there is a venous congestion, that's why when we are anesthetizing these patients or we are managing these patients in ICU, their head should be raised and the neck and the head should be kept in the center, because we should not be rotating like this or like this, because once you rotate on side, it will compress the internal jugular vein and it will decrease the venous drainage. When it decreases the venous drainage, the blood will be increased, total amount of blood on the venous side will be increased. That will increase the ICP, because ICP is nothing, it is the interaction of the contents of the cranium with the cranium itself. What are the contents? Brain substance, CSF, and then you got arterial blood and the venous blood. So if you increase one thing, the other thing should be decreased. But if you rotate the neck to one side, so it will because brain is already diseased, you are dealing with a diseased brain, so already fluid has been accumulated there. On top of that, if you decrease the venous drainage, it will cause venous congestion. It will tremendously increase the ICP, intracranial pressure. It can go into decompensation, it can cause ischemia of the brain and further damage. It can enhance the infarction of the brain also. Now, the problems of neurosurgical anesthesia, all things are avoided. Avoid vasodilatation, avoid hypercarbia, avoid hypoxia, avoid pain and anxiety. All these things we have gone through in the previous section. Then induce hypotension, and then depress the cerebral activity by giving sedative agent. Avoid drugs which increase the CMRO2. It's very simple things. You can do it when you are dealing with a patient who has got neurosurgical or the neurological activity in the brain. Now, basic consideration when you are anesthetizing these patients or when you are controlling these patients in a critical care unit, what are the conditions which is requiring intracranial surgery? There are different type of neurosurgical procedures they are doing. Then intracranial space occupation. Either it is a brain tumor or it is hematoma, which is occupying the brain substance, which is occupying the brain cavity. What is the size of that? And whether it is compressing the normal brain or not. Then subarachnoid hemorrhage. Then pituitary surgery. Even if the rest of the brain is normal, but they are operating on the pituitary. This has got some special consideration. Then cerebral arterial insufficiency. So then head injury. All these things one has to keep in mind when you are anesthetizing the patient for these particular conditions. Now, in little bit in detail, what are the problems related to neurosurgery? Problems related to disordered physiology. Problems related to cerebral effect of anesthetic agent. Problems related to technique of anesthesia. And then the special requirement of these things you should be keeping in your mind. And you should be composed. You should have all these things in your mind so that if they ask you in the exam also about neurosurgical anesthesia, you describe in this way, then the examiner will automatically know whether you know the subject, you understand the subject. There's no point calculating the small points or telling the small points, but you group wise, if you tell the examiner will immediately point out that you understand the subject. Now, there are general problems when you are anesthetizing these patients for neurosurgery, and there are problems related to cerebral perfusion. General tube, you will have to consider a tube. What size of tube you are using and what type of tube you are using. Whether it is a non-kinkable or kinkable or not. That's very important. Then access to head. Once you have anesthetized the patient, will you have access to the head or not? And you will not have access to the head because the neurosurgeon is operating there, and how can you share with him? So you should take up all the steps that you don't need to go there again and again and completely fix the tube and you are away from the patient. Then the patient's temperature should be monitored, central temperature as well as the peripheral temperature. It should be the difference that is important. Difference of central and the peripheral temperature tell you perfusion of the tissues, perfusion of the periphery. That will give you the idea about the cardiac output of the patient. Blood loss. So it should be always vigilant to look at the blood loss. Then diathermy interference. They put the diathermy pads and it can interference with your electrical activity which you are monitoring on the monitor. It can interfere with your ECG and other things. Then respiration, that if the patient is breathing spontaneously or the patient is on a ventilator, and you should be constantly looking at the respiration. Then consciousness. Some of the procedures you might have to, like you have to make them wake up during the operation, so that you should use such a technique that you should be able to bring the conscious level back, like on Parkinsonism type of surgery. Then pneumonitis. These patients who have been unconscious, for example, the patient of head injury, or the patient has got a brain tumor and the patient is not, the Glasgow Coma Scale is not 15/15 or less, they might have vomited and aspirated. So you will have to scrutinize the lung, activity of the lung also, and see if they have got pneumonitis or not. Then pneumonitis should be managed properly afterwards also. And then if the patient, you're looking after the patient in the critical care unit, then you should be very careful that the patient should not regurgitate, or patient should not vomit and should not be aspirated into the lung. And this is very important. This is the main contributor towards the mortality. Then hypertension, you will have to control the blood pressure also during operation and post-operatively. Airway is far away from you. That you should be very vigilant about to maintaining the airway. Post-op convulsion, you will take the steps to avoid the post-op convulsion, and intraoperatively and post-operatively. You should start using the drug, anticonvulsant drugs. As we know, you have seen the neurophysician is using it quite oftenly. Convulsion, if you have got a convulsion, it will increase the cerebral blood flow. When it increases the cerebral blood flow, it will increase the CMRO2. If it increases CMRO2, it will increase the intracranial pressure. So that is dangerous. That will damage the brain cell. Then related to cerebral perfusion problems like arterial CO2 tension, you should be constantly monitoring this. continuously monitoring it, entitled CO2. It's very important because you ventilate the patient when you are anesthetizing these patients and take the CO2 up to 30 to 35 millimeter mercury and never ever below 25 because this will have severe vasoconstriction. So we have to keep the arterial blood flow a little bit on the respiratory alkalosis. Now hypertension and hypotension, then venous pressure, central venous pressure, then the drugs which you're using, and then avoid the hypoxia. So these are the problems which we keep in our mind when we are dealing with patients. Essential elements of good neuroanesthesia. Again, some of the things are coming again and again, but if you are specializing in this particular neurosurgical anesthesia, you should be very clear about it and you should know every step one by one. And their remedy also. Safe airway, production of low ICP, avoidance of hypoxia, avoidance of hypercarbia, avoidance of coughing and straining, profound muscular relaxation. This is very important. When you are anesthetizing neurosurgical patient, there should not be any muscle tone present there. They should be completely relaxed because if you got abdominal, particularly abdominal muscle tone is increased during neurosurgical anesthesia, that will push the diaphragm up, that will increase intrathoracic pressure, that will decrease the venous drainage from the brain, and that will increase the ICP. So that adds to the quality care of the patient. They should be given muscle relaxant at a regular interval. You should have a neuromuscular monitor there, and it will be best if you can give continuously by infusion muscle relaxant, or should be kept, because most of the neurosurgical patients in the post-op period, they are ventilated for 24 to 48 hours. Never ever try to wake them up. Keep them sedated, keep them paralyzed, and put them on a ventilator. After 24 hours, assess whether they are ready to be taken off the ventilator or not. Jaldi na kare isme. Haste makes waste. Then clear cerebral venous drainage, obviously, when you are keeping the patient. Now, mostly these patients are kept head up and straight. It depends when you are doing the posterior fossa operation, you are in a prone position, or you are sitting up position and neck is bent. Or if you are operating on lateral side, you might put it lateral side. But in all the positions, your neck should be straight. Neck should be straight, so that it should not kink the internal jugular veins. So it should not interfere the venous drainage from the brain. So it should not increase the ICP. That's very important. And देखने में तो लगता है कोई फर्क नहीं, थोड़ा सा फर्क पड़ेगा. आपको देखा होगा जब मैं आईसीयू में सबसे पहले मैं देखता हूँ what is the position of the patient, and it is always wrong. Every time I have to remind them to keep the neck straight and head up at least 35 to 45 degree head up. Low CVP, maintenance of cerebral perfusion pressure. You will only know it when you know the mean arterial pressure, and then you know the ICP, and you will calculate the CPP, cerebral perfusion pressure. No reflux response to pain. Never ever check the reflux response to the pain. The patient should be completely pain-free. Patient should be completely sedated, completely pain-free, and completely should have muscle relaxation. These things should be kept in your mind. That will give you the quality anesthesia. Rapid and complete recovery of consciousness. Now, it will be only you will predict in a preoperative period that this is the operation going to happen, and this will be the outcome of this patient, and what is my plan for postoperative period. You make your plan for postoperative period in the preoperative period, and accordingly you stick to it. Right? Now, pre-op assessment. As usual, we look at a central venous cardiovascular system, ECG, X-ray, control of arterial hypertension, and coronary artery disease. And if there is any coronary artery disease, whether it needs to be proceeded first, or whether this neurosurgical emergency is there, or it is a planned operation. And accordingly, you control these things. And hypertension, as I have already told you, auto-regulation in relation to hypertension is very important. because if you can wait, bring the autoregulation within the normal range, 60 to 130 mean arterial pressure, right? Because hypertension will shift the curve towards the right. Lower limit will be shifted to the right and upper limit will be shifted towards the right. When you drop the blood pressure, if it is still shifted, has been shifted to the right, if you drop the blood pressure during anesthesia, you are bound to drop it. So when you drop it, brain will suffer ischemia and you will damage the brain. Respiratory system, you try to look at chronic respiratory disease, winter cough, sputum production, antibiotic therapy, physiotherapy. These patients are usually planned 7 to 10 days prior to operation. If it is a planned surgery, there should be respiratory system and cardiovascular system should be controlled. CNS, conscious level, assessment of ICP, then headache, vomiting, papilledema and other things. So it is a routine pre-op assessment. Then diabetes, whether it is controlled or whether it is on therapy. What type of therapy? The patient on oral hypoglycemic agent, you should know how to control the diabetes when the patient is undergoing anesthesia. What will happen in the post-op period? We won't give any tablets in the immediate post-op period. So they should be on the continuous infusion. This is called sliding scale afterwards, because this is a major surgery. They are bound to be on the sliding scale. Hydration and the balance. Now, these patients should not be, usually they are dehydrated when they are brought to hospital. So, hydration should be proper and it should be according to the central venous pressure. And patient should be brought in water and electrolyte balance, acid-base balance, and then in nutritional balance. So at least it should be water balance, electrolyte balance, and acid balance before you anesthetize the patient. And keep it like this in a post-operative period also. Now, drug therapy. Usually these patients are on anticonvulsants, on steroids, on antihypertensive, or antidepressant. It should be documented and you should know what will happen to this patient in the post-operative period or in the intraoperative period. So you should take the history in detail and document these things that the patient has been on these drugs. And you should keep in your mind what will be the interaction with the drugs which you are using during anesthesia. So that has to be kept in mind by the anesthetist. Then the blood should be arranged and suitability of an artery, because you are going to put the arterial line intraoperatively. So just look at the arterial line. Afterwards, central line should be there also. For any major organ surgery should have arterial line, CVP line. So arterial line, you look at the arteries which is suitable. This artery, and you should have done Allen's test before. Pre-medication. Avoid narcotics as a pre-medication. Avoid because they cause the respiratory depression, they depress the conscious level and cause the cerebral vasodilatation, increase the cerebral blood flow, and they can cause the pupillary constriction. That's a very important parameter to look at for the assessment of neurological assessment of the patient. Then they call vomiting also. Pre-op vomiting and post-op vomiting. So one should keep in mind when you're using narcotics. Avoid narcotics like droperidone, detachment from the surroundings. If you're using droperidol, butorphanol, it's not narcotics, droperidol or the butorphanones. So they detach you from the surroundings. So fentanyl, respiratory depressant. Then if you're using antiemetic, you should know the interaction with other drugs also. ये सिंपल वही नहीं होना चाहिए, पकड़ा आदमी को टेबल बैठा है वही एनेस्थीसिया आ जाए. तो हो ये रहा है आजकल ये कि हाउस ऑफिसर वही एनेस्थीसिया दे रहा है, प्रोफेसर वही एनेस्थीसिया दे रहा है. देयर हैज़ टू बी सम डिफरेंस, राइट. वही दे रहे, दिया प्रोपोफॉल, मसल रिलैक्सेंट दिया, लटा दिया, ट्यूब डाल दी और वेंटिलेट कर दिया, उठा दिया, भेज दिया, राइट. एवरी ऑर्गन सिस्टम has to be dealt separately, and you should change your anesthetic technique according to the disease patient is suffering from. Previously it used to be you try to bring the organ into the normality to give anesthesia. Now you have to choose a drug, doesn't matter what sort of abnormality in other organs of the system. So you choose the anesthetic technique and the drugs according to the disease patient is suffering from. So Then benzodiazepines, they are the drug of choice as a pre-medicant. It is an anticonvulsant. It does not have any much effect on the intracranial pressure. It does not cause the respiratory depression. But it depends how much you are using, which benzodiazepine you are using. There are 43 types of benzodiazepines. Now, all the benzodiazepines, if you give in a higher dose, they are neuromuscular blocker. They cause non-depolarizing type of muscle relaxation effect. So always keep in mind when you're giving Dorbicum, go on giving Dorbicum, then we think, the patient is not breathing properly. It's not depressing the respiratory center. It can, if you have got very deep sedation, but it mainly causing a neuromuscular blocking effect. Patient muscles are flaccid, and you check the neuromuscular with the monitor, you look at the neuromuscular activity. Beta blockers with the pre-medication, some of the patients we use it for laryngeal when you're putting the tube in. Now, induction of anesthesia, prevent hypoxia, prevent hypercarbia, minimize the response to laryngoscopy. When you put the laryngoscope in, you have already stimulated the sympathetic system. Always keep in mind, whenever you put the tube in, so you should take up the steps to suppress the sympathetic response to laryngoscopy, right? Then minimal neck movement also. कभी इधर हो जाए, कभी इधर हो जाए, आपको नजर नहीं आ रहा, कभी लेटे उठे आप उसको घुमाते रहते, neck घुमा दी तो intracranial pressure बढ़ेगा. You are damaging the patient. So it should be kept in the center. And whenever you intubation, I've never seen any difficult intubation in whole of my life, in the whole of my 50 years of career of anesthesia. And most of the time the people used to call me when there is a difficult intubation in Nishtar, most of the fault of the anesthetist, because they are not making their position proper, or the patient position is not proper. So then the problem is solved. I've never used any camera and other things in my life. I've seen the necks being like this. But most important thing is you make your own, the person who is going to anesthetize, going to intubate the patient, should make his own position first. What should be your position? Then make the position of head and neck and the height at which the table is. Make yourself comfortable. Then you should check, you have checked all the equipment first, and then in which hand you will hold the laryngoscope. Then in which hand the laryngoscope will go in. And you should have an adequate size of the tube, and you should have still it with you. You will not find any difficulty. This is nonsense. Every table which I know this is difficult intubation. Most of the difficult intubation can be dealt by this. Although there are some difficult intubations also, it doesn't mean that you should not have equipment for that. You should have equipment. But most of the problems can be solved out by doing this thing only. Your self position should be adequate. The patient's position should be normal, or it should be required by the intubation. Then laryngoscope should be perfect in your hand, right? Sequence of induction. Cooperate patient to hyperventilate. If the patient is conscious, ask the patient to take deep breath. You will see, if you sit down and you take deep breath for a few minutes, you may use your PCO2 first, then I'll ask you to hyperventilate for a few minutes. Then you take your blood for blood gases, your CO2 will be very much down. You can take it to 25, 30 also. The carbon dioxide is washed out very quickly from the lungs because it diffuses 200 times more fast as compared to oxygen. It comes into the alveoli very quickly. From the alveoli, according to physical law, so it very slow to come out. But if you increase the respiration and increase your tidal volume, it comes out very quickly. So you can lower the PCO2 very quickly. I always used to ask the patient, take deep breath and take fast breathe. So CO2 comes down to 30, so there is cerebral vasoconstriction. You have already taken a one step to lower the ICP. Pre-oxygenate these patients, right? Then intravenous thiopentone or slow propofol. Give muscular relaxation, do the laryngoscopy, and spray the local anesthetic there, lignocaine. Rapid gentle intubation. Now gently you put your laryngoscope in and put the tip of your laryngoscope should be in the vallicula. Vallicula is the junction of the tongue with the epiglottis. Put there and lift upward and forward. Don't make the upper teeth as a fulcrum. You will see there is something lying there, hole there, laryngeal aperture you see. And directly go there and very gently put the tube in. ये नहीं कभी इधर मारा, कभी इधर मारा, कभी इधर मारा. So that will stimulate the sympathetic system, and that will not only physically damage the laryngopharynx or larynx, it will also increase the ICP. It should be rapid, gentle intubation. Now, still on the sequence induction, tube should be non-kinkable tube. इधर का ले ऐसे मोड़ लें, उसका होल पेटेंट रहे. Now, inflate, check and fix. Once you put the tube down, you are looking at it. Once the upper part of the cuff of the tube is below the vocal cord, then you inflate the cuff. Okay? Then you check whether it is properly inflated or not, or properly in the auscultate on the both sides. Then you fix the tube. Keep your hand there to stabilize it till you have fixed it. ठीक, ये सारी चीज़ें चेक कर दें. Now hyperventilate to the PCO2 of 25 to 30 millimeter mercury. Now you have given all the things, your tube is in, put on the ventilator and hyperventilate to 25 to 30 millimeter mercury. And you are giving nitrous oxide, oxygen, depolarizing muscle relaxant, and perhaps neuroleptics or whatsoever, fentanyl or anything you are using it. Always cover the eyes and always use the airway. Even your tube, even if the patient is relaxed, even if the patient is deeply sedated or patient cannot move, but always put your airway along with the tube also. So that if the patient perchance comes around, should not chew the tube. And when it chews the tube, it will cause hypercapnia. And when hypercapnia is induced, it will cause cerebral vasodilatation. If it causes cerebral vasodilatation, it increases cerebral blood flow. If it increases cerebral blood flow, it will increase the ICP. At the same time, it will cause increase in CMRO2 also, cerebral metabolic rate of oxygen utilization. Although it looks very small thing, but that adds to your quality of anesthesia. And ये पेशेंट नहीं कहेगा 10 साल के बाद ऐसे आए कहते हैं मेरे तो न्यूरॉन उड़ गए, मेरी याददाश्त खराब हो गई. ये नहीं पता था डॉक्टर मेहदी ने 15 साल पहले इसको एनेस्थीसिया दिया था. ठीक है, हाँ, क्वालिटी इज़ वेरी इंपॉर्टेंट. जिस हालत में पेशेंट आया उसी हालत में जाए. प्री ऑपरेटिव जो कंडीशन है पेशेंट में उसी में जाए वापस. ये ना हो, ये नहीं कि वो बीमार है तो उसका मतलब है कि उससे वर्स ना हो के जाए पेशेंट. At intubation, you can use beta blockers to suppress the laryngeal response to laryngoscopy, laryngopharynx response to laryngoscopy. Local anesthetic spray, you can use 2 to 4 milligram trimethoprim, it is antihypertensive. Large dose of thiopentone or other intravenous anesthetic agent at the time of intubation. Small dose of intravenous anesthetic agent before laryngoscopy. There are different things you can do, but if you are given adequate analgesia to the patient, adequate relaxation and adequate sedation to the patient, and then you can use these beta blockers and other things also spray the vocal cords. ये ना हो कि पेशेंट का आप वोकल कार्ड पे स्प्रे कर रहे हैं, पेशेंट लारिंगोस्पाज्म में चला जाए. Never ever trust the dose of the muscle relaxant. Always check on the neuromuscular monitor. Every patient, irrespective of type of the patient who is going to have muscle relaxant, should have a neuromuscular monitor. Attach होता है, उससे पता लगता है क्या response है. देखा कभी? देखा करें. Right. Causes of increased ICP during induction. You are inducing the patient. What can cause an increase in intracranial pressure? Muscle fasciculation. If you use suxamethonium will cause fasciculation, muscle twitching. That will increase intracranial pressure. Then increase systemic blood pressure when you are inducing the patient. So it means you will have already taken the steps to keep the blood pressure stable. Never ever let the blood pressure go up when you are inducing the patient. Then distortion and compression of jugular vein. The same things are again and again. Jugular veins are very important. If you are monitoring the ICP, then you rotate your neck or you are compressed on one side, you will see what is the effect. Because if you look at the graph of ICP, at the stage of reaching to the decompensation, so you will see little bit narrowing of internal jugular vein can increase tremendously intracranial pressure. Avoid succinylmethonium to avoid the fasciculation. Avoid rise of blood pressure. Decrease the duration of intubation. Shorter the period of intubation, the less will be the effect on the ICP. ये नहीं कि ट्यूब डाल के बड़े आराम से स्लो ऐसा ऐसा आप ट्यूब डाल रहे हैं, ठीक है, ऑटोनोमिक रिस्पॉन्स इज देयर, राइट, इट विल इंक्रीज में. तो आप जाएं क्विकली, सी ट्यूब डाली, निकालो लंग उसको फौरन, उसको पकड़ लें ट्यूब को, इन्फ्लेट द कप, चेक द ट्यूब एंड देन यू फिक्स द ट्यूब. फिक्स करके कनेक्टेड विद द वेंटिलेटर विच इज ऑलरेडी एंड विच इज बीइंग यूज्ड ऑलरेडी. वो डाला हुआ, उसके आगे बैग लगाया हुआ, वो चल रहा है, आपने इसके पैरामीटर सेट कर दें, यू कनेक्ट विद इट एंड इनहेलेशन एनेस्थेटिक एजेंट्स. Venous pressure. Central venous pressure will increase the ICP. Intracranial venous pressure will increase the CSF pressure, will increase the ICP. They are all interdependent. Now, central venous pressure, if it is increased, what are the factors? Insufficient expiratory time. Always make it sure that expiratory time is adequate when you are ventilating these patients. There should not be any induced PEEP, IPAP, induced PEEP, so IPEEP. So there should not be like that, because the gases should come out completely from the lung. Because if you leave some gases in the lung, so it will increase the intrathoracic pressure. When it increase the intrathoracic pressure, it will decrease the difference between the central venous pressure and pressure in the brain and venous pressure in the thorax. So there will be less drainage of blood coming over there. That will increase the ICP. Right? Cuffing and straining, that will increase the central venous pressure. Now, flexion, extension, and rotation of the neck. Increase abdominal muscular tone, as I already mentioned. If you increase the muscular tone, it will push the diaphragm up, it will increase the intrathoracic pressure, it will decrease the pressure gradient between the brain, venous pressure, and the central venous pressure. That will reduce the drainage of the venous blood from the brain. Now, perfusion pressure is always, in every organ, perfusion pressure is mean arterial pressure minus mean venous pressure. यही होता है ना, एक organ है, इसको blood आ रहा है, under some pressure, this is called mean arterial pressure. Then venous drainage हो रही है, उसका mean venous pressure देखे, इनका जो difference है, greater the difference, more will be flow. Less will be difference, less will be flow. And that will cause a problem. But in case of brain, mean arterial pressure minus ICP, that is called cerebral perfusion pressure, and that should be 75 to 80 millimeter of mercury. Normally 75 to 80 millimeter of mercury. If it increases, one should be worried. If it decreases, even then you should be worried about it. Now, cerebral perfusion pressure less than 40 to 50, it depresses the autoregulation. Cerebral perfusion pressure less than 30, it will decrease the cerebral energy stores, ATP, phosphocreatinine, and it will increase the lactate. That's why the cerebral perfusion pressure is very important. Now, inhalation anesthetic agent decrease the mean arterial pressure, increase the ICP, and decrease the cerebral perfusion pressure. That will cause brain ischemia. Local ischemia, that will also cause ischemia. So you will have to keep an eye on the cerebral perfusion pressures. Now, preparation, monitoring and measurement. When the patient is, you have anesthetized the patient, what should be monitoring? Arterial pressure and heart rate, whether it is invasive or non-invasive. Continuous ECG monitoring. Continuous temperature. Temperature means difference of central temperature and peripheral temperature. Then CVP monitoring. Then pericardial auscultation. We usually have stethoscope put over there because that will tell you about the mechanical activity of the heart, right? ECG tells you electrical activity of the heart. To monitor the mechanical activity, you should have stethoscope here, should have long tube, and should be intermittently, you should go on auscultating it, right? It's very important. We tend to forget the old things, but these old things are the gold things. We should remember physical examination is very important all the time. Then end-tidal CO2 is very important continuously, as we have got on our monitor. When measure end-tidal CO2, it will tell you the PaCO2. Then ICP, if you can measure the ICP, put the transducer there. It's a simple cheese. Neurosurgical anesthesia theater mein, you should be able to measure the ICP. Then there are special monitoring also. Jugular bulb, oxygen and carbon dioxide. It's very rarely done. Cerebral blood flow measurement continuously during surgery, and CMRO2 measurement also continuously. In some other advanced center of neurosurgical anesthesia, it's centered, so they measure these things. But you should know at least there are things. Blood and heat loss. You measure the blood loss and replace the blood. At least you should start replacing in case of adult. If it is more than 50% of your blood volume, if the blood is lost, provided your hemoglobin and hematocrit are normal before you started anesthetizing the patient. If the patient loses more than 50% of their blood, it should be replaced by blood. Up to 15%. Though you can replace it by the fluids that can compensate your blood volume. In case of neonates, if they lose more than 10% of their blood volume, so you should replace it by blood, right? So every patient, in general, any patient you are going to anesthetize where you expect that there will be blood loss, you should always calculate the blood volume of that patient. You can go on measuring the blood loss. Make your habit as an anesthetist that always calculate the blood volume of that particular patient with that particular weight and write it down on your notes. And if they lose more than 15% in case of adult, always replace it by blood. And in case of neonates, if they lose more than 10%, always replace it by blood. Right? Up to 10 or 15%, it can be compensated by giving fluid. In case of neurosurgery, always give saline solution, not a lactate solution, or not a 5% glucose, right? Now, fluid type you will have to choose is a saline. Intravenous you have to choose. Space rescue blankets. We don't use any rescue even where the rescue is required also. Water circulating blankets, if it's cold. So they've got a blanket around the rest of the body and circulate the warm water through it to keep the temperature normal, right? But you have to mention, even if you are not doing it, iatrogenic injuries. Take the care of eyes because they are operating over there all around. Peripheral nerves, that should be put the pads under, and you should have an inflating and deflating type of devices to increase or decrease the venous return from the vessels to avoid the DVT. Vulnerable pressure areas, they should put the cushions there. Blood stagnation in the leg should be avoided by putting those जो आप डालते हैं क्या देते हैं आप stockings. Yeah. These things, you think it is very simple, very common things, but you will have to mention. You have to mention in the exam, you have to mention in the paper also. Because don't presume that the examiner already knows it. No, the examiner wants to know you know it or not. Okay? Then position for surgery. It should be positioned such a position, it should allow the venous return, avoid flexion and rotation of the neck, frontal craniotomy, supine brow up position. Brow up क्या होती है? Supine सीधा, head up है, ये brow up position. Right? Then वो automatically बना लेंगे neurosurgeon. Then temporal and posterior fossa, lateral or oblique position. Or prone position or sitting up position. Right? करवाई कभी न्यूरोसर्जरी किसने? हाँ, ये बड़ी मजेदार सर्जरी होती है. मेरा तो आई लव न्यूरोसर्जिकल एनेस्थीसिया. और neonatal जिससे सारे लोग भागते हैं. Prone position, you free the abdomen, secure the endotracheal tube. Whenever you put the patient in a prone position, your abdomen should not have a pressure on it. If there is a pressure on it, it push the diaphragm up and same way sequence start हो जाता है. और tube को make it so that you have secured properly endotracheal tube. It is fixed, is not kinking. Which as you are using non-kinking, doesn't matter. But if you are using ordinary tube, then make sure it does not kink. Then sitting up position, always keep in your mind, sitting up will cause venous pooling, the legs. It can drop the blood pressure. So keep in mind blood pressure. Then if they open the cranium, you can have air embolism also. To keep in mind air embolism. Put the LDECT on, operate the LDECT or something called some stethoscope here, it can give you the noise if the air goes in. If air is in, it is so provided. There are some conditions in which the air can go into the heart, but don't let the air go into the pulmonary circulation. If it goes into the heart, just to turn the patient on the left side, lower the head of the patient. Lower the head, turn on the right side. Sorry, left side. Where will the air go? It will go in the apex of the right ventricle. Push the center venous catheter up to the tip of the right ventricle and suck the air out. And these apparatuses can they detect up to 0.2 mils of air also, right? This is called Durand's position, D-U-R-R-A-N, Durand's position. Left lateral, head lower down, put the cerebral catheter there and suck the air out. It takes 2 minutes only. If you are vigilant and if you know it, this is happening with the patient. बजाय इसके कि वहाँ से एयर जाए, पल्मोनरी सर्कुलेशन में जाके स्ट्रक हो जाए, पल्मोनरी एम्बोलिज्म करें और उसके बाद आपको पता चले, ठीक है? You should be very vigilant. Anesthesia, any person who does not have a fast reflexes should not come to anesthesia. Anesthesia intensive, you should have very fast reflexes and you should be very vigilant. आपने देखी होगी typical, if you go into the Google and or Facebook पर जाके आप एंटर करें गूगल में, what should be the ideal anesthetist? Ideal anesthetist के कितने हाथ होने चाहिए, कितनी टांगें होनी चाहिए, रोल्स होनी चाहिए, आंखें ऐसे घूमती होनी चाहिए, ऐसे चलता रहना चाहिए आपका. आईसीयू में बैठे हो तो ऐसे बैठे हो, आपका सारा ऐसे चलना चाहिए. एनेस्थीसिया अगर दे रहे हैं आप बैठे हो, हर चीज़ आप मॉनिटर कर रहे हो बैठे आँख से, ठीक. Maintenance of anesthesia, basic. Hyperventilation up to 25 or 30 millimeter of mercury with nitric oxide and oxygen, 60 to 40 ratio. Regular incremental doses of non-depolarizing muscle relaxant, or you can give continuous infusion also. Then droperidol or fentanyl or phenoparidine, there are different choices of drugs. Thiopentone or propofol infusion to keep them asleep. Yeah, patient should be asleep, patient should be sedated, patient should be relaxed, and patient should be oxygenated. And the carbon dioxide should be washed out, right? Propofol infusion, 1.5 milligram per kilogram per state, 100 microgram per kilogram per minute, but these are immaterial. According to the response of the patient, you give these things. IV therapy in these patients, intraoperative or postoperative. There should be 0.9% saline. Never ever give normal saline. Give 0.9% saline. जो कहते हैं normal saline. There is nothing like normal saline. Normal solution, one which contains 1 gram equivalent in 1 liter. ये आपने physics में FSC में पढ़ा होगा. What is the normal solution? Normal solution, one which contains 1 gram equivalent in 1 liter. This is 0.9 gram. It's not a normal. It's less than normal. So whenever you order, you always say 0.9% saline solution. Don't say normal solution. It's a misnomer. गलत कहते हैं लोग. So if there is a loss, up to 15% of the blood loss, provided the hemoglobin was normal before the operation, so you replace it by blood after 15%. Up to 15% you should give saline. Always remember that the patient is starving. When you plan your fluid therapy, your patient is starving for the last 4 to 6 hours. You calculate how much was the requirement per hour for this patient. Normal requirement. How much is the normal requirement? Fluid. 1.5 to 2 ml per kilogram per hour. You calculate, for example, 70 kilogram man. He requires 2 ml per kilogram per hour. He needed 140 ml per hour. For the last 6 hours, how much he has lost? 140 into 6, 840 ml he is already short. If it hasn't been given, you give this during the anesthetic period. Plus, every hour you have to give this one, 2 ml per kilogram per hour. Plus, extra loss. Extra loss if the patient is losing. पेट खुला हुआ है, छाती खुली हुई है, इस किस्म का ऑपरेशन, ब्रेन खुला हुआ है, सेंसिबल लॉस भी हो रहा है. Plus blood loss. So anesthetist has to be very vigilant to keep the patient euvolemic, right? Active reduction of ICP. How will you actively lower the ICP also? Dangers of increased ICP. In the close, if the skull is closed, it can cause coning. Coning is through the foramen magnum. ऐसे धकेल देगा. If the skull is open, it can be herniation. Different portion of brain going into different portion. That's why we are worried about it, to reduce ICP. ठीक? Now, identify and correct the cause. Check the position. There should not be any hypoxia. There should be adequate ventilation to have the PCO2 between 25 to 30. CVP should not be raised. Adequate muscular relaxation. Eliminate the cerebral vasodilating drug. It is the same thing again and again, but you will have to mention these things, right? So ICP is very important. Active reduction of use of specific method. You use osmotic diuretics. You can use loop diuretics also if there is hypervolemia, right? Then CSF removal. हम CSF remove करते हैं पीछे से. अगर नहीं है तो वो कहता है, सर्जन कहता है कि अभी भी ब्रेन जो है ना वो बड़ा टर्जिड नहीं है, टर्जिड है, बड़ा सख्त हुआ है. उसे कहें कि आप डाल निकाल लो, लैटरल वेंट्रिकल से निकाल लो, साथ करके वो और रिलैक्स हो जाए. Then metabolic depressant also we give, so that brain की activity should be depressed and should not increase the ICP. Recovery. Anticonvulsant drugs should be used in the recovery period, whatsoever is available, whatsoever is the drugs recommended. Anti-inflammatory drugs, dexamethasone. Result is depression of consciousness, damage to cranial nerve, respiratory depression. These things can happen by the operation. They might be having depression of consciousness, they might be having damage to cranial nerve, they might be having a respiratory depression, right? Depending on what was the operation, where was operated. Very vigilant, it can be 100% recovery. But, so it's all centers are there, all the cranial nerves are coming out of that. It takes hours and hours to operate on posterior fossa. But the reward is very good if they can do it properly. हमारी है ना आया फिर रही है उसको है ना posterior fossa meningioma. No closure of dura till the blood pressure is greater than 100. ड्यूरा खोला हुआ उन्हें कहें कि जब तक 100 से ऊपर ब्लड प्रेशर ना आए उस वक्त ड्यूरा बंद ना करें. IPP versus spontaneous, you have to decide whether you are going to keep on intermittent positive pressure ventilation or you will let the patient breathe spontaneously. It will be better first 24 to 48 hours ventilate these patients. Ventilate to the 25 to 30 millimeter of mercury of CO2. And there should not be any hypoxia, should not be any hypercarbia in the post-op period. Close observation of blood pressure, pulse, hypoxia, hypercarbia, urine output per hour. And per hour urine output, in a normal urine output is 1 ml per kilogram per hour. And that is a normal production. When it goes down to 0.5 ml per kilogram per hour, then we label it as oliguria. Any patient in the hospital should produce more than 0.5 ml per kilogram per hour. If they don't produce it, then scrutinize the patient whether it is a preoperative pre-renal problem, renal problem, or post-renal problem. If it is a pre-renal problem, we should manage it. If it is a renal problem, call the nephrologist. If it is a post-renal problem, call the urologist. But you should monitor it per hour, because they might have produced 300-400 in the first hour, then he's not producing anything. I'm saying 4 hours में 400 आ गया. And that's not, every hour it should be monitored. Monitor the ICP, then conscious level, Glasgow Coma Scale. Analgesia should be adequate. Fluid balance should be kept within normal range. Nursing care. It's a very rare thing to have a nursing care, right? So it is the nursing care which saves the patient. Right. Position of the patient according to at what area of the brain has been. So it should be such a position in which there will not be hindrance of the venous drainage from the cranium. Oxygen therapy is optional, but you should give at least 24 hours oxygen, depending on the saturation and the PaO2. We put the patient on oxygen, looking at the SpO2, saturation. We take the patient off the oxygen by looking at the PaO2. Always remember it. ये नहीं देख के कहते हैं ऑक्सीजन तो बड़ी आ रही है. Saturation ड्रॉप होती है तो we put them on oxygen. लेकिन उतारने के लिए you look at the arterial partial pressure of oxygen, PaO2.